So, sir, shall we start now?
Yeah.
Okay, sir. So it's 3, 2, 1. Over to you, sir.
Very good evening, doctors. I am Dr. Kapil from JB Pharma, and on the behalf of JB Pharma, I accord warm welcome to all of you for this national webinar on choosing the right ARNI for the right reasons. Doctors, as you are aware, ARNI is one of the pillars of GDMT therapy, and ARNI is a co-crystal complex consisting of 6 molecules of sacubitril, 6 molecules of valsartan. It has 18 sodium cations and 15 water molecules that make it is a unique patented co-crystal salt. And that's why we have organized this webinar to understand why choosing the right ARNI is important. To talk more on the subject, today we have with us Dr. Rajat Sharma, sir, and it's my honor to introduce him. He is currently working as director and lead consultant. He is a cardiac electrophysiologist at Heart Rhythm Services, Fortis Hospital, Mohali. And sir, welcome to this webinar, and over to you for your talk.
Okay, thank you. So welcome everybody, and it is going to be a very important topic so far as our clinical practice is concerned, and how the way we should be managing our patients. As we all know that ARNI, since 2014, after the paradigm HF, it has become a very core medication for the heart failure of any spectrum, particularly the heart failure with a reduced ejection fraction. The whole idea of having this discussion of an ARNI, how we should choose the ARNI, is very important. The reason why he has already introduced the complexity of this molecule. So it is not a very easily manufactured molecule, because once we don't maintain the sanctity of this molecule, probably on a long run or maybe in the short run, we may encounter some suboptimal outcome. So the questions before we actually start discussing about this is, this whole idea of having this research actually is just to reinforce the concept of quality and efficacy so far as any heart failure treatment or any cardiovascular medication is concerned in particular. And because the heart failure is such a dangerous kind of problem where the mortality is so high, it is very important to actually choose the medications correctly and rightly. So we must try to ensure always that the medication which has been actually tested in the RCT, where it has gone through all the phases of the trial, like the phase 1, phase 2, and the phase 3 trial, we all know about that particular molecule in this kind of situation, that is a LCG 696, which was actually tested in heart failure population. So we all know the data of the paradigm HF, and that is probably the reason why it featured in the guideline. And when we are talking about the selection of the medication, the initial cost, definitely when we are choosing an innovator, because of the amount of economics that are actually put behind the development and the research of this compound, they will be little more expensive than what the generic has, because the generic do not have such kind of luxury or the reason of investing money in such kind of situation. So economically, although it is going to be a little higher, but we need to know about the pharmacoeconomics so far as the long-term outcome of this heart failure patients are concerned, because it is a dynamic situation where the patients tend to have a declining course very subtly, and eventually they can go into advanced heart failure situations. So when we're talking about an innovator, whether all the available drugs are the same as the innovator, We do not have a right answer at this point of time. It may be or it may not be. The may not be the reason for that is, suppose you are talking about a simple molecular structure, whether it's an aspirin or some kind of pantoprazole or some antibiotic, there is a different issue. But when we are talking about a complex molecule, whether it is a dabigatran, whether it is a ARNI or many other medications, even the clopidogrel, they had run into some kind of problem when they try to manufacture because of the characteristics of those molecules could not be replicated continuously, thereby leading to excessive adverse event and probably suboptimal clinical outcome. So at this point of time, it is very difficult to actually quantify the clinical outcome of this two distinct group of medications, but it is a legitimate idea just to find out whether the core issue of the molecule has been preserved as an innovator or not. So that is precisely what we have done it. So it will be, as a physician, it will be difficult for anybody actually to distinguish the distinction between these two compounds because we are mostly economically driven. So when a medication is there, so we tend to practice the prescribe this medication without knowing or understanding whether this particular molecule may have some kind of untoward or undesirable suboptimal effect on a long term or not. So when we talk about a innovator molecule or a particular complex molecule, it depends on many factors. So the pharmacological characteristics of that molecule has to be maintained at any cost so that it should be effective in our clinical practice. So the same thing that the efficacy and the safety. So whether the efficacy will be similar or the efficacy will be compromised, whether safety will be the same or we are bound to have some excessive side effects. So that we have seen in few of the molecules that have been actually manufactured other than the innovator, where the patient tend to have some kind of excessive side effect or some kind of suboptimal effect. So far as the heart failure, we all know it is a very, very common problem these days because of the cardiovascular risk factors for heart failure are so high, whether it's the hypertension, diabetes, or survivors of the coronary artery disease, and eventually more and more detectable cardiomyopathies in our clinical practice. And more importantly, it is a very, very progressive disease. So without we knowing on a daily routine clinical practice follow-up, it becomes so important that we have to identify whether the patient is clinically stable or doing well or not. Because if we try to be very, very casual in this kind of assessment, then there is a chance that the patient can slip onto some kind of progressive heart failure disease. Although we can't really prevent it, but we can actually optimize the treatment so that the declining course can be shortened. So far as the mortality of the heart failure is concerned, it is an extremely deadly disease, almost like a cancer. So many of the cancer where the mortality is high, the heart failure tends to have a similar kind of mortality on follow-up, like 5% mortality will be close to around 50%. So this is very important. And so far as the cost of the treatment, recurrent hospitalization is one of the major factors that actually contribute to the cost along with the mortality or the morbidity of the patient. So we tend to have some kind of recurrent heart failure hospitalization, which actually economically burden the patients during the process of treatment. So we need to reduce this heart failure hospitalization at any cost. So if we look at the National Heart Failure Registry, which was published in 2022, so if you look at the data, we have predominantly more of patients with a heart failure with a reduced ejection fraction. And if you look at the Trivandrum registry, they actually echoed the same kind of data up close to around 60%. So in an Indian scenario, we have more of heart failure with a reduced ejection fraction because of the ease of diagnosis, and we may be missing some of the heart failure with a preserved ejection fraction, which can be equally important. So if you look at the Indian data, particularly if you look at the Kerala registry, so the ARNI medication, which was actually very rarely or very minimally used in heart failure with a reduced ejection fraction. And if you look at the other 3 or 4 compound, that is the beta blocker or the MRA, it tends to be very low. And if you look at the National Heart Failure Registry, the usage of the guideline directed medical therapy was not optimal, it is suboptimal. And if you look at the ARNI consumption in particular, that has been significantly low. So that is a concerning kind of thing. And that needs to be improved if we want to improve the overall outcome of the heart failure patients. So in that National Heart Failure Registry, close to around 4% or less than 4% actually patients were receiving ARNI in whatever dose. Forget about the optimal dose. So the ARNI actually has changed the heart failure treatment after the publication of the paradigm HF in 2014, and the amount of primary and the secondary outcome benefit that it has shown single-handedly has actually contributed to the class 1 recommendation in the heart failure with a reduced ejection fraction. So various of the guidelines, whether it is an ACC, AHA, or the European Society guideline, they actually stressed upon this ARNI data from the paradigm HF, and it secured as the class 1 recommendation along with the various other 3 pillars that we all know about, like MRA, beta blocker, and the SGLT2 inhibitors. So now what is the difference between this innovator and the generic? So if you look at the innovator ARNI, it has the strength of the evidence across the heart failure continuum with an extensive real world data that we have already seen. And it has also been backed up by the extensive research that has been gone in, like in the phase 1, phase 2 trials before the paradigm was conceived. So when we're talking about an innovator ARNI in this particular scenario, we have the real data historically that this molecule in the same form has been tested in animal studies, phase 2 studies, and phase 3 studies. That is how the paradigm HF has become such an important heart failure trial, and which has shown some tremendous outcome benefit. If you look at the review process or the requirement of a new drug and the requirement, so if you look at the most of the data, most of the factors of the new drug, they are pretty much the same except the bioavailability. So that actually becomes an important factor so far as the clinical efficacy or pharmacological efficacy of a particular drug is concerned. So a drug requirement do not always need such kind of bioequivalent study, but so far as the ARNI is concerned, it is important because of the thing that we have stopped. So if you look at the animal study or the bioavailability study that we all have for the innovative drug only, because we do not have that data for the generic compound. So we are little concerned about how these generic compounds are going to behave when they are given on a long term. So that is the basic purpose of finding out whether we are going to have some kind of significantly different outcome so far as these two groups of drugs are concerned. So the key difference between an innovator and a generic compound, which lies on the animal studies and the bioavailability, that is the key difference. So if you look at the core of an ARNI or any molecule, particularly the sacubitril valsartan co-crystalline structure, it is very important to have a three-dimensional co-crystalline structure that most of the generic sacubitril valsartan probably they do not have. That we have tested by this kind of pharmacological intervention, and the stability of the product is very, very important. The medication needs to be stable for a decent dissolution profile so that the medication is effective appropriately so far as the dissolution of the sacubitril as well as the valsartan is concerned. So if you have an unstable product or the stability is not as good as the innovator, then you are likely to have some kind of problem clinically. And the stability is actually dependent on many factors that we will be discussing. So far as the bioavailability is concerned, so there has to be uniform bioavailability. That needs to be documented, right? So if you look at the other stabilizers like surfactant and other kind of medications, other constituents of the ARNI is concerned, they tend to be appropriate so that we do not have some problem with the absorption of the compound or some kind of local GI side effect or some kind of allergy or excessive adverse event because of the surfactant or the stabilizers. If you look at the efficacy of the product, the efficacy lies on the pharmacological characteristics of this complex molecule. And the most important thing is the co-crystalline formulation of this ARNI. So that needs to be recreated so as to have the similar kind of therapeutic efficacy. And as we discussed, like the adverse event are really related to the other constituents of the molecule. So we need to be 100% sure that we have the right kind of stabilizers or the other stabilizers so that we don't have any excessive side effect. So the core issue is a bioequivalence. What do you mean by a bioequivalence? Bioequivalence means when we have two pharmaceutical products that are supposedly bioequivalent, then they should have the pharmaceutically equivalent and the bioavailability after administration or ingestion in the same molar dose should have a similar degree of effect with respect to the efficacy and the safety. So this becomes a challenge when we any particular drug which has not been tested in heart failure population. So it cannot be tested in a normal individual, and we should think that it will be reciprocated in a diseased individual. So the rate and extent of the absorption are assessed by using the plasma drug concentration time curve following the ingestion of the particular molecule. So that has to be done. So the bioequivalence actually is dependent on so many things, and the rate of absorption and the extent of absorption is very, very important. So we need to know how quickly the drug reaches the bloodstream, typically measured by the time to reach maximum concentration or what is called as a Tmax thermostically, and the extent of the absorption, which we know that the area under the curve is actually made following of the medication. And we know that the extent of absorption is actually pharmaceutically legitimate. So, coming to the key parameters which actually decides bioequivalence of a particular molecule is the Cmax, Tmax, the EC, and the T hat. So these all has to be seen. So what related requirements are? Look at the ESC and the European Medicine Agency data. The acceptance criteria is established in the
So, Doctor, sorry, I think there's a technical glitch. Dr. Rajat Sharma has some connection issues, I think. He will be just joining in. Uh, Achal or Raju, who is there, can you just try Dr. Rajat's mobile number?
I am connecting with him. Dr. Sharma will join in just 2 minutes.
Hello.
Hello? Dr. Sharma will join in 2 minutes. He's connecting. Hello, am I
Can
audible?
you help Dr. Rajat to log in, or somebody is there with him who can help him to log in?
Yeah, he's doing it on his own. He said just he'll join in just 2 minutes. I think yeah, sir is here.
Yeah, sir, we can. I think you have joined back. So can you please share your screen and yeah,
The sharing option is gone.
yeah, sir, now we can see you, sir.
You can see me, but I can't see the slides.
Okay.
Dr. Kapil, if possible, you can share slides from your end.
Yeah,
Shall I share the slides?
is the slides are visible now?
No, sir.
Not yet, sir.
So shall I share the screen?
Yes. From where it is disconnected, just tell me that.
Yeah. So you're talking about the bioequivalence?
Yes.
Yeah.
Can you make it full slide? Yeah.
Yeah.
Can you give me the control?
So I have given you, if you can. So I've given you this, just a try changing the slides. No.
Can you try to do that once more?
Yeah, yes. So it is waiting for you to control your screen. It's coming. Sir, is it okay if I change the slides from, if you say?
So, next slide. Yeah, so the key parameter that we all know about the bioequivalence actually is dependent on various critical pharmacological factors, whether it is the Cmax or the Tmax or the area under the curve and the T hat. So that will actually decide about the resolution profile, the stability, and eventual bioavailability of a particular product. Next slide. So if you look at the regulatory requirement, it doesn't necessarily mean that it has to be 100% bioequivalent as compared to an innovator brand, but it should be falling between 80% to 125% of the confidence interval so far as the various pharmacological characteristics like the Cmax or the area under the curve is concerned. So if you are able to manage those levels of bioequivalence, so probably we are good for a appropriate therapeutic outcome of that particular molecule. Next. So there are many factors actually which can actually have an effect so far as the bioequivalence is concerned. So formulation differences, like it has some inactive ingredient that we are talking about, or the drug delivery system that may have an impact so far as the desired therapeutic impact is concerned. And the manufacturing process again is very, very vital, particularly for complex molecule like this. And we all have the variables so far as the patient variables, whether it is the age, comorbidities, renal dysfunction, and so on, which also may have an effect so far as the clinical efficacy of that particular molecule is concerned. So when we're talking about these variables, we have some variables which are actually related to the drug that we are taking, and there are certain kind of variable which is not in our hand, and probably we have to tighter or manage the appropriate dose in those kind of scenario so that we can achieve the appropriate therapeutic efficacy. Next slide. So if you have a decent bioequivalent molecule, probably it will have a predictable therapeutic effect so that we can actually expect the similar kind of outcome benefit as in the RCT. When we talk about the cost effectiveness, definitely the innovative brand which has actually involved in huge amount of money so far as the research, development, and the various phases of the trials are concerned, and including an RCT, it is going to eventually be little costlier than the generic brand which has not done that. So there will be some limitation so far as the formulation specificity and the patient safety is concerned. That is very, very important when we are using a life-saving medication, which is very, very complex so far as the molecular structure is concerned. Next slide. So this all we have already discussed, like some minor pharmaceutical ingredients of the molecule can have some kind of impact so far as the excessive side effect, GI tolerability, excessive hemodynamic impact of a certain like a hypertension and so on is concerned. Next slide. So the data already exists for various molecules, including the cardiovascular drugs, where they have seen that over 30% of the studies actually believe that the innovator compounds actually they are more efficacious as compared to the non-innovator drugs, and that has been proven all over the world. It is not something new. So when you are talking about a complex molecule, it is very, very vital, important to know that the medication that we are prescribing is having the similar pharmacological characteristics, whether it is the bioequivalence, stability, dissolution. Next slide. So we all know about this ARNI, which is the unique salt complex. Next slide. And it contains sacubitril and valsartan, 6 molecules each, along with sodium and water in that compound. And it is very, very intricately and very uniquely manufactured, so that we need to maintain this particular supramolecular complex when we are trying to renovate some of the generic compounds. So we need to identify that which are the molecules they actually are having unique structure as an innovator. Next. And this unique composition actually replicates into various characteristics of the ARNI, whether it is a dissolution or it is a stability, because that is very, very important so far as the eventual clinical effect of this ARNI is concerned. Next. So when we took up this particular study with an idea that we need to distinguish between the characteristics, pharmacological characteristics, not the clinical characteristics, pharmacological characteristics of these two groups of compound, because we are prescribing this medication to a very, very important group of disease like heart failure, so that we are expected to achieve the similar kind of therapeutic efficacy. Next slide. So what we did is we compared the various brands of the secretary valsartan for presence of this co-crystalline structure, which is then very, very core important characteristics of ARNI. Next slide. So this is all we have discussed regarding the background of the ARNI structure, because it is very, very important to maintain this co-crystalline structure so that we have the required therapeutic outcome. So we tested this particular drugs so far as the pharmacological characteristics is concerned. Next slide. So we actually accumulated 16 marketed products and try to put them into various kind of pharmacological intervention so far as the differential scanning calorimetry or the powder X-ray diffraction and sodium content analysis and the dissolution study, so that we understand that the medication that is available or we are writing or we are prescribing has a similar kind of characteristics as an ARNI or an innovator ARNI. Next slide. So these are the detail of the PXRD analysis that will not go into the detail. Next slide. So it basically talk about the co-crystalline structure of the particular compound, and this is a complex pharmaceutical intervention that most of the pharmacologists they actually are well versed about, who are doing in the research or they're in the quality control. So if you look at when we did this particular powdered PXRD, so there was hardly any generic compound. Actually, they perfectly aligned to the unique co-crystalline structure that we saw in the innovator brand. Next slide. So when we put that thing, then we had two distinct curves. The two peaks actually are seen, which is called the melting pattern of a ARNI, and we need to maintain that unique melting pattern so as to know that the molecule actually is thermodynamically stable. If you don't have a stable molecule in vitro, then probably we are not expecting a appropriate pharmacological outcome also. Next. Next. So if you look at the dissolution study in an acidic pH, so the innovator molecule actually showed a higher dissolution than the other molecule, other generic compound. So that is a very, very vital factor if you are expecting a appropriate therapeutic effect of this ARNI. So the dissolution was significantly variable so far as the generic compound is concerned. Next slide. Only 3 of them actually matched. So if you look at the dissolution profile of the sacubitril and the valsartan of the innovator versus the generic compound, they were significantly different. So innovator ARNI actually exhibited the substantial release of the both the components of the sacubitril valsartan within 30 minutes and 45 minutes, surpassing than the other generic compound. So that probably will reflect on the therapeutic effect of the ARNI, whether it is the innovator or the generic compound is concerned. Next. And if you look at the sodium content, only 3 of the generic compound actually match to the innovator brand so far as the sodium content is concerned. Because as we know that it is an extremely hygroscopic molecule. More of sodium will cause some kind of instability of the product, and particularly in a heart failure situation, it may have some kind of negative therapeutic impact. So having an appropriate sodium value is very, very important. Next. So the conclusion of the study is we had some problem with the co-crystalline structure so far as the majority of the generic compounds are concerned, which may have been inappropriate or suboptimal therapeutic impact, and such variation in the pharmacological characteristics, whether it is the bioavailability and efficacy is concerned, it may have an important impact so far as the clinical outcome is concerned. So we need to have an appropriate melting point, which is a marker for the stability. We need to have a appropriate dissolution profile in vitro so that we know that both the components are dissolute in a appropriate manner once ingested, and we need to have a appropriate sodium content as the innovator so as to expect an appropriate therapeutic outcome. Next. So we all have the data of the innovator ARNI, whether it is an RCT or various RWE in the last 10 years. It has shown a significant impact so far as the primary and the secondary outcomes are concerned, and over 60 million people who are suffering from heart failure, they have got an appropriate effect of this particular ARNI that we have been doing, prescribing. And because of the high mortality associated with the heart failure, it is very, very important to actually select the right drug so that we can probably salvage this highly dynamic heart failure patients so far as the mortality and the morbidity is concerned. Next slide. So we have the data of the innovator brand, and we have close to around 10 years of experience of this product and over 230 clinical trials, both the RCT and the real world data we have gathered, and we have the right kind of impact so far as the cardiovascular outcomes are concerned, just like the RCT in various ethnic and geographical locations. In India, we have the data of more than 1,500 patients which has been enrolled in this RCT, and in the real world data as well, we have come across the similar kind of outcome benefit so far as the ARNI is concerned, and particularly the data of the innovator ARNI. Next slide. So the conclusion of this talk is we have the data of the ARNI which has been tested in the RCT and the RWEs, and we have an appropriate therapeutic or the clinical outcome for over 10 years. And this is the molecule which are actually features in the guideline. Now, the story will be whether we can actually, when we are talking about two groups of drugs, and because of this primary data which has come up, so far as the difference in the pharmaceutical characteristics of these two groups of drugs, time will tell that how these two groups of drugs are going to actually affect our heart failure population on long term. Thank you.
Dr. Kapil, you are on mute.
Yeah, thank you, sir, for an excellent talk and explaining all the aspects of a generic drug, especially when a generic drug is a very complex structure like sacubitril valsartan. And you also touched upon the co-crystal technology and its advantages. So just a couple of questions from the audience. Sir, as you in your study, you found out that none of the other Indian brands generic brands were having co-crystal structure. So what are the clinical implications for a clinician? What he should take from this?
So if you look at the ARNI, the core issue of the ARNI is the co-crystalline structure. So when this particular drug was tested, and when they tried to break into 25 milligram, which is called a low dose therapy in heart failure population, they did not get the similar kind of therapeutic outcome benefit. Because we don't know in a such a complex molecule, when you break it into half, that how much of sacubitril and how much of valsartan you are giving to the patient. Had it been a simple molecule and you make a 25 milligram tablets into half, like 12.5, 12.5, that is a different issue. But here is the composition of two compounds, and that too in a very, very complex arrangement so far as the pharmaceutical composition is concerned. So breaking those kind of complex molecule may actually have an impact on the eventual therapeutic outcome. And if you look at the sacubitril, if you are breaking the 25 milligram, I mean the 50 milligram sacubitril valsartan, the sacubitril that remains behind, it cannot be more than 12.5 milligrams. So the therapeutic effect of the sacubitril is suboptimal to have a desired therapeutic outcome. So you will still continue to have a very high NT-proBNP and so on.
So there can be clinical differences when
There will be certainly a therapeutic, I mean the clinical outcome benefit differences, but it is going to take a long time if we want to really quantify the amount of difference between these two groups of compound, because we need again an RCT to actually test these two groups of drugs. I don't know whether it will be ethically correct or incorrect, but if it is correct also, we will have a significant amount of follow-up data so that we have to quantify the outcome benefit.
Yeah, so in fact, in the literature, you can find some evidences where innovator was compared to generics. And
Yes.
as you also said, they found that innovator was supposed to have good efficacy profile as compared to the generics.
Yes.
Sir, one more question which has come. Sir, in your opinion, for complex molecules which have co-crystal technology like ARNI, does only a bioequivalent study suffice the purpose of approval, or they should
Probably not.
also probably not,
Yes.
or they should do more safety and efficacy data like the biologicals. For biologicals,
Correct.
even if you have the same structure, they are required to do a phase 3 study for approval.
Right. Right.
But in India, only because we have the guidance of bioequivalence, and that is how companies
Yes.
follow.
Again, the bioequivalence has to be tested in sicker population, and as you said, in a phase 3 trial, just to be 100% sure that these compounds actually have the similar kind of impact as the innovators so far as the clinical outcomes are concerned.
And sir, as you were discussing about the cost benefit. So suppose a person, or so if the about the generic brands, they don't have the same effectiveness because they don't have the co-crystal structure. So how much do you anticipate the increase in the cost burden for that patient?
So if you look at the ARNI's pharmacoeconomic data, although that was only for the innovator brand, because nowhere in the world you get a generic ARNI, so far as my knowledge goes. So if you look at the innovator ARNI, which is considered to be expensive so far as the layman is concerned, it actually saved money. The saving came from reduction of the heart failure hospitalization, eventual prolongation of the patient's lifespan at whatever age group, and the quality of life. And if you're trying to compare between the innovator and the generic, suppose we are expecting the generic will not be that effective as an innovator, there will be certainly an excessive amount of heart failure hospitalization that will incur some extra amount of cost. We'll have some kind of excessive amount of adverse event that will result in premature discontinuation of the medication, if the patient has something excessive hypotensive effect, so far as the inappropriate dissolution of the valsartan particularly, and if you have some kind of constituent or the stabilizer which has been used in the generic, which can cause some kind of excessive adverse event, then that will have an impact so far as the patient's quality of life or the cost is concerned. So far as the innovator, this has already been studied. So far as the adverse event, that is already tabulated and they have been quantified. We all know about the expected adverse event and positive cardiovascular outcomes are concerned. So we have a real good data so far as the innovator is concerned. We don't have that for the generic.
Yes, yes. Yeah, I think so. That was the question, sir. Sir, any final comment you want to make? Then we can wind up this session.
Yeah, so far as the heart failure outcomes, so far as the ARNI is concerned, we all have to believe on the data that we have. We have some data to fall back. Forget about the pharmacological characteristics because as a clinician, we hardly understand about this or we are really sensitive about this particular pharmacological characteristics of a particular molecule. But if you look at as an clinician, you will certainly see some kind of differences between a similar drug, whether it's a clopidogrel, whether it's a ticagrelor, whether it is a dabigatran, whether it is a paracetamol, whether it is a pantoprazole, and so on. You can actually expect an appropriate effect, pharmacological effect, if you prescribe a product which is already has been tested and which has come to the limelight. Like if you look at the interventional cardiologists, most of the people, they prefer Brilinta than any other ticagrelor. So there has to be some real reason for that. If you talk about the clopidogrel about 20 years back, we have been seeing some kind of excessive amount of stent thrombosis. That actually forced to do a similar kind of study in Hyderabad, where they could see that just like a Plavix, which was the innovator clopidogrel, only 4 or 5 clopidogrel which has been produced, they could have a similar amount of bioequivalence or the bioavailability. Clopidogrel is not such a complex molecule. Then also this was the thing. So in an ARNI kind of situation, probably the therapeutic impact will be something more because the basic core issue of the ARNI molecule has not been properly taken care of. So I will be really concerned if we have some kind of suboptimal therapeutic outcome, but we need to see and take a decision.
Take a decision. Yeah, thank you, sir. I think the message is loud and clear from your side that the generic brands, they don't have the co-crystal technology or the structure, and therefore it can impact the effectiveness and the safety in the patients.
Right, sir.
Yeah. So, sir, I think now I would like to thank you, sir, for an excellent session on why choosing the right ARNI is important in HF patients. And I would like to thank you once again for an excellent talk. Thank you, sir.
Thank you.
Thank you. Thank you all. Thank you, organizers.